My best practice topic is to choose between like biological or mechanical valve. So as you see, I'm very young cardiac surgeon, let's say, so maybe I have a different point of view. I'm maybe not that conservative than older or elderly cardiac surgeons when it comes to the choice of the preference of biological valve. So I have to say we all know about the guidelines which tell us 65 years for aortic valve, that's the cutoff for the mechanical and the biological valve, and a little bit less, like 60 for the mitral valve. I must say that I don't take it that seriously anymore, because we all know about the literature that the biological valves are getting better and better in terms of endurance and long-lasting and long-term outcomes. So even when I have a 55-year-old patient, he decides to get the biological valve after that I talk to him about the possibility that it is going to deteriorate or it's going to calcify much sooner than a mechanical valve, but he is willing to accept it just not to have the possible side effects of oral anticoagulation. I think nowadays, with the emerging techniques and the better and better biological valves, it is actually, I think, time even for the guidelines to cut down with the age. We all know it also from the literature and from the ongoing big studies that the biological valves are going to have a better long-term durability than we used to have it in the past 20 and 30 years when everything started. So it's my personal choice, of course, to say like between 55 and 65, so I think it's a gray zone nowadays. And it's also important that the patient has an annulus which is large enough to implant a large biological valve, which makes it possible to make interventional treatment 10 or 15 years after the surgical implant. So you don't have to redo surgery again after those years. So when you have an annulus, which is of course quite small, like 20 or 22 millimeters, then of course it's going to be a little bit more complicated. Then you can do also an annulus enlargement plastic to have a large enough biological valve to have the possibility to do some interventional TAVIs later on when it deteriorates even in the young patients. So my personal choice when a patient comes who wants to have the mechanical valve, even when he's 55 or she is 55, it can happen because referring cardiologists also have their best practice and their best practice point of views. And sometimes patients already wish to get a mechanical valve who are around 60 years of age. Then of course, I'm going to accept that, and I'm also going to talk to the patient about the possibility that there is a biological valve available as well for them when they're 60 years of age. That is the gray zone, but of course we have to talk about also about the oral anticoagulation and the side effects.